Welcome to this BTOG podcast series. My name is Newsom-Davis. I'm the Vice Chair of the British Thoracic Oncology Group Steering Committee and a medical oncologist treating lung cancer. This is part of a regular podcast series entitled BTOG Does, where I have an informal chat with experts, and hopefully we're going to go through some of the important questions about lung cancer diagnosis, treatment, and all other things lung cancer related. It's important for me to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything that we discuss. So this week, I'm delighted to be joined by my colleague, Neal Navani. Neal is a consultant respiratory physician at UCL Hospitals. He's the Associate Professor of Respiratory Medicine at UCL and a general guru when it comes to things all lung and all cancer related. Neal, welcome to the BTOG Does podcast series.
Thank you very much, Tom. Pleasure to be here.
So we're going to talk about diagnosis and staging. So BTOG does diagnosis and staging of lung cancer. We're going to start off at the beginning. So we're so familiar with doing a whole bunch of investigations and tests for lung cancer. We tend to stick to CTs. What should we be CTing and what should we not be CTing for our routine 2-week wait referrals where we have a clinical suspicion of cancer?
Thanks, Tom. So our NICE guidelines currently recommend that we carry out a CT scan with contrast and include the neck, chest, and upper abdomen. The upper abdomen obviously including the liver and adrenals. But I think it's a good question to ask because whereas the NICE guidelines recommend that, you could envisage actually that we might want to scan other areas depending upon the clinical history or symptoms. And there's always been an area of controversy about whether we routinely image the brain. So very clear guidance from NICE, but I think there's also a room for maneuver when we initially assess our patients, and we should really be scanning anywhere that's guided by symptoms as well.
So it sounds like you're probably not doing a CT down to the pelvis if you've got no symptoms. To do CT neck, are you specifically adding in CT neck for that? If someone says CT chest, does that cover sufficient neck anatomy, or would you be routinely adding a CT neck to your cases?
No, I routinely add CT neck. Actually, usually the CT chest only barely covers the supraclavicular area, so it would be much better routinely to include the neck. We all know how useful and important it can be to detect lymph nodes in the neck. It just gives us a really good opportunity for a quick diagnosis and really important for staging as well. So I would specifically add in a CT of the neck. Yeah.
I think I need to change our practice in a hospital. So PET scans are much prettier. You get fantastic pictures. Everyone loves a PET scan, but we're not routinely doing them for all cases, at least not in my hospital. When should we be doing them? They are much more expensive. They tend to be not in the local hospital unless you're in a big cancer center like yours. When do you do them? When should we be doing them? When shouldn't we be doing them?
Yeah, so PET scans, as you say, are a really precious resource. We've got, very limited number of PET scanners in the UK. They're a bit of a bottleneck for us in our lung cancer pathway. So I think it's right that we use them in appropriate circumstances. So again, NICE has got pretty clear guidance on this. So anyone in who is being considered for treatment with curative intent should have a PET CT scan. So generally speaking, this refers to patients with stage 1 and to 3 disease, and that would be the most common reason to do a PET CT. Increasingly, we treat people with oligometastatic disease with curative intent, and in those cases, a PET CT is entirely appropriate. We wouldn't usually recommend a PET CT in a patient who presents with advanced disease, so M1B or M1C. However, I know many centres also use PET CT to help radiotherapy planning and also to help biopsy strategies. So there are a number of indications, but the core indication really should be for patients who are having treatment with curative intent.
Thank you. So you've done your investigations, your CT neck included. You find someone unfortunately who has advanced stage disease. They've got a primary in the lung, they've got some lymph nodes, they've got some distant mets. Where should we be planning our biopsy? Are you going for the primary or are we going for something more metastatic? What's the best practice?
Yeah, thanks, Tom. And I think practice does vary here nationally and also internationally. So I think the basic principles are, first of all, in a patient with advanced disease, we want to choose a site that is going to be the most convenient for the patient to cause the least morbidity to that patient. We also want to optimize the sample so we get as much tissue as is feasible in order to carry out all of the appropriate biomarker testing that is now required. So we've got those two major principles that guide us. The third thing is whether we need further staging information. How confident are we that this patient has advanced disease? Could that adrenal lesion be actually a benign adenoma? And therefore, if we can also use the biopsy to confirm our disease stage in certain cases as well. So a couple of important considerations there. I think generally we are moving away from bone biopsies. They are uncomfortable for patients, and often the analysis and the decalcification process will cause DNA breakdown that's not going to allow us to do any of the molecular tests that we want. So bone biopsies I would strongly urge to avoid unless there's a very clear and large soft tissue component to it. And the other thing that's emerging in the literature is perhaps the use of pleural fluid, and this is perhaps an area of controversy. A couple of studies now, including one from the National Lung Cancer Audit that I was involved with, has suggested that the failure rate for molecular analysis from pleural fluid is twice as high as any other biopsy or tissue acquisition technique. And I think we've all had cases where we do pleural fluid, we do a cell block, but actually there isn't enough material for further analysis. And actually, I personally have changed my practice slightly when it comes to a patient with a large pleural effusion, where I will only aspirate to dryness a pleural effusion for therapeutic purposes. And I would often be looking for other sites for further tissue. That's perhaps a little bit controversial and not yet in clinical guidance, but there's a paper, as I say, from the National Lung Cancer Audit, a paper from Kevin Blythe's group in Glasgow showing something similar, where it delays pathways. But something perhaps to consider when we're faced with a patient with advanced disease.
That is very interesting. That's very helpful. And I certainly agree with avoiding bone biopsies. It nearly always cross-links the DNA. You try to do molecular analysis and you get a big fat no. So I would concur with that one. Okay, so let's think about our stage 3, our locally advanced patients. These are the ones we hope we're going to be going down a radical treatment, probably chemoradiotherapy with perhaps a bit of immunotherapy thrown in for good measure, or perhaps with surgery. How would you diagnose and stage these guys, the stage 3 patients?
Yeah, so these are probably the most challenging group for us in terms of diagnosis and staging. I think when we are seeing a patient with potential stage 3 disease, I think we need to think about a couple of things. First of all, we want a tissue diagnosis. So we want confirmation of a subtype of lung cancer. And increasingly, we want to know the PD-L1 status, and perhaps in the future as well, we'll be looking at genomic testing for that group as well. So that's the first thing. We want adequate tissue. The second thing is we want the most accurate disease stage that we can possibly get. So we want to know which lymph nodes are involved throughout the hilum and the mediastinum, so we can accurately stage that patient. The third point is knowing as much as possible about the physiology of the patient to understand what treatment is going to be suitable for them. So as a minimum, when I see a patient with stage 3 disease in my clinic, I'm going to be thinking about doing a PET CT as soon as possible for systemic staging, and also to get an idea of lymph nodes. I'm going to be doing an MRI brain routinely. That's recommended by NICE. We know that there's a high incidence of occult, when I say high, sort of 5 to 10% incidence of occult brain metastases in patients with stage 3 disease. And then I'm also thinking about the patient's physiology at the same time. How can I improve their performance status? How can we maximize their ability to go through treatments? I'm going to request full set of pulmonary function tests, including transfer factor. I'm probably going to do an echocardiogram. I'm going to talk to them about smoking cessation if that's relevant. And I'm going to also potentially refer them for pulmonary rehab if that's appropriate and available as well. So a number of considerations early on. And then we also, at the same time, within that bundle of care, we want to book a biopsy test. And invariably in patients with stage 3 disease, that's going to be an endobronchial ultrasound. So it's quite a big package of investigations for our patients. It does take time with our patients with stage 3 disease to go through it, but I think it's really crucial to get all of that information together so that we can then discuss in our multidisciplinary team meetings to work out the treatment options.
That is brilliant. Thank you very much. For those of you unclear on what endobronchial ultrasound or EBUS is, we will come on to that in 1 second, so don't despair and don't panic. We're going to work our way back up the staging. What about our stage 1 patients? In other words, these are the guys who have got the lung mass, they haven't got any obvious nodes that you can reach with your EBUS. Do all patients with a stage 1 cancer in whom we are planning surgery need a biopsy? Or are there situations where we don't? So I guess I'm really thinking about the ones where it's a less accessible mass, people are more concerned about the impact of a pneumothorax on that. What's your take on that?
Thanks, Tom. So my personal view on this is that we should aim to get tissue in as many patients as possible. It's nearly always helpful. There are occasions where we can mistake benign lesions for tumours. So an area of organising pneumonia, an area of granulomatous inflammation, even tuberculosis can really closely mimic a lung cancer. So my default position is that we take a biopsy as much as possible. In certain cases, that's the risks of taking a biopsy may well outweigh those potential benefits of certainty, particularly perhaps in patients with very poor respiratory reserve, in whom perhaps we're considering SABR. And if we have good evidence on imaging, good evidence of growth, we would often like to assess volume doubling time. We can calculate a Herder risk score, which is a risk prediction model incorporating SUV max from the PET scan. If we put all those things together, we can have fairly high level of confidence that that particular nodule is malignant. And potentially in those cases, it might be reasonable if the MDT agrees not to take a biopsy and go ahead with treatment. 2 caveats though. 1, if that patient's going for surgery, they should have a frozen section ideally before a lobectomy. If not, they'll end up having a sublobar resection with the possibility of further surgery being required. The second caveat is a really interesting study that was published last year in the learned respiratory journal Thorax that showed a worryingly high prevalence of pleural-based recurrence in young patients who were having CT-guided biopsies. And the study was really interesting. It came from the Far East, but did seem to provide fairly strong evidence that doing CT-guided biopsies in patients with very peripheral lung tumours, adenocarcinomas in particular, in young individuals was associated with a higher incidence of pleural recurrence. That's obviously needs to be confirmed, but it is something that people are worried about theoretically for many years. And it might be interesting to watch that space going forward.
Fascinating. I've always said to patients, biopsy don't increase the chances of cancer recurrence, but maybe that is different. Okay, so thinking about bronchoscopies versus EBUS, just for some of people may not be familiar, briefly, Neil, for the amateur's guide, what is the difference between a bronchoscopy and an EBUS?
Thanks, Tom. This is a subject close to my heart, as you know. So bronchoscopy is a flexible tube placed down the nose or mouth into the airway. It moves around sort of using a paddle at the top end. We're able to place instruments down a working channel that allows us to take biopsies. But the main point about it is you can only see within the airway. So it's like being within a tunnel. You can only see what's on the in front of you inside the tunnel. One of the issues we know with lung cancer is that the lymph nodes are outside of the airway. They're in the mediastinum, or there might be a lung lesion that's outside of an airway. And this is where endobronchial ultrasound really has transformed our practice. So the equipment itself is fairly similar, except in the tip of the bronchoscope, there's a miniature ultrasound processor that's integrated into the tip. So we have a light to see where we're going, as well as an ultrasound processor. So we have multiple screens available to us when we're doing the procedure. We're able to have a view of the inside of the tunnel, so the inside of the airway with the white light. But using the ultrasound, we can put the telescope against the side of the wall, and we're able to obtain an ultrasound view of the mediastinum, the lungs, the heart, the esophagus, all of those structures within the chest that previously were generally inaccessible to respiratory physicians. The scope then has a working channel down which we can pass a needle, and then under that direct ultrasound guidance, we can introduce a needle through the airway wall and into the target structure. And now with modern ultrasound equipment and small needles, we can sample lesions that are 3 or 4 millimeters. Alternatively, we can put large 19 gauge needles down there. The total diameter of the scope is usually around 7.5 millimeters. So this is, still very small and extraordinary technology. And hopefully as technology improves and as the ultrasound improves, that will give us more room to put bigger instruments down so that ultrasound can go further out into the lung periphery. We'll be able to put bigger needles down for sampling, and then in the future, I'm sure we'll be able to pass ablation catheters down for therapy as well.
And I've seen doing buses, and I think they're amazing. As someone who, the most specific thing I do is click a chemotherapy prescribing button, I'm always amazed by anything that you guys can do. When we're an MDT and a colleague in the MDT says, "Oh, I think this patient needs a staging e-bus," what do they mean by that? What is a staging e-bus, and what are you looking at, and why are you doing it?
Yeah, thanks. This is a really important area that's emerged, I think, over the last 3 or 4 years, really. So we divide e-bus procedures now into 2 types of procedure. One is a diagnostic procedure only. So this is essentially placing the telescope in the airway and sampling the largest and most convenient lymph node in a patient with advanced disease. So we're not concerned about staging the mediastinum. We're simply focused on sampling the most convenient area to obtain the highest quality sample and material for biomarker testing. So that's a diagnostic procedure. What we now are trying to push and trying to encourage respiratory physicians to embrace is a staging procedure. So this is a different technique, it's a different approach, and it requires a slightly different mindset. So this is a systematic approach where the e-bus scope is used to sample lymph nodes in a systematic way. So we will start with N3 lymph nodes. So if you have a right upper lobe tumor, we'd start at the left hilum. We would visualize the lymph nodes there. We would then move up to station 4L, left paratracheal, station 2L, upper left. We would then look at the subcarinal station 7 lymph node before swinging over to the right. Still look at the upper paratracheal lymph nodes, 2R and 4R, still N2 lymph nodes, before finally sampling, or looking at rather, the N1 ipsilateral hilar lymph nodes. So we would have this N3, N2, N1 visualization process. And as we go, we're making notes about all of the lymph nodes, ideally taking pictures with our ultrasound probe, and looking then to sample any lymph node that's greater than or equal to 5 millimeters. So this is then going to mean that we are sampling a variety of N3, N2, and N1, usually lymph nodes for a patient. This allows us to really get good quality staging. And the prospective data now suggests that that's the most accurate way of accurately staging the mediastinum, and that's now also been embraced by the most recent NICE lung cancer diagnostic update in 2019.
Neal, that is a fantastic summary. Thank you very much for sharing your expertise. So my thanks to Neal Navani. As you can tell, respiratory physician extraordinaire at UCL and good friend of BTOG. Thank you everyone for listening. We hope we gave that an insight into diagnosis and staging of lung cancer. Of course, for more information on BTOG, including educational events and other podcasts, we believe this is going to be a minimum a monthly podcast. You can, of course, visit www.btog.org. Thank you very much for your attention. Goodbye.